This event is titled Invisible Disabilities, Long COVID and Other Post-Infectious Chronic Illnesses. It is presented by the Health and Disability Partnership at the Massachusetts Department of Public Health, along with the Massachusetts ME, CFS, and FM Association. It was presented on September 15th, 2021.
This event is technically one of the quarterly meetings of the Health and Disability Partnership. The event includes ASL interpretation and live captioning. Our panel moderator is Rodrigo Monterrey, MPA, pronouns he, him. Rodrigo is the Deputy Director for the Office of Health Equity at the Massachusetts Department of Public Health. He has over 20 years of public health experience, including providing technical assistance and training on health equity. Formerly, Rodrigo served as co-chair of the New England Regional Health Equity Council, and at the Bureau of Addiction Services, Rodrigo developed trauma-informed care guidance, deaf and hard of hearing treatment, and behavioral health disaster response systems. Welcome, Rodrigo.
Imagine getting what you think is a common cold or flu, or even an insect bite, and then never getting better. Two of our panelists will discuss their experiences with post-infectious chronic illness and disability, one with long COVID, the other with Lyme disease. A third panelist will discuss her experience living with ME/CFS. The full name is myalgic encephalomyelitis, chronic fatigue syndrome, a disabling disease which is often, though not always, post-infectious. Before we turn it over to our panelists, we want to mention that in the interest of time, not all post-infectious chronic illness groups are represented here today. There are many more that we will not cover today. Our panelists are each living with a disabling chronic illness. They will each have a total of 6 minutes to address 3 questions, so about 2 minutes per answer. I will introduce each panelist just before they speak, but I will not repeat the questions each time. I will let you panelists know when you have 1 minute left. After all panelists speak, we will hold a Q&A, question and answer session, with the questions that participants have typed into the Q&A box during the presentations. Now, the 3 questions we have for the panelists are: 1, please share with us your illness and disability story. What was your life like before you got sick? What was it like as you got sick? And what is your life like now? What are your primary symptoms? What else do you want to share about your illness and disabilities? This time speaking as a person from your particular community. That is, as a Black woman, a Latina, an agender person, an autistic person, a mother, a college student, a person with additional disabilities, etc. And 3, what are some ways your state government agencies, including the Massachusetts Department of Public Health, could help you? A disclaimer, the Health and Disability Partnership is an advisory body only and cannot implement these requests, but they are still important for all to hear. Now, on to our first panelist. Kayla Shiner, pronouns they, them, is an autistic agender person diagnosed with Lyme disease and on permanent disability. An artist and writer, they explore the intersection of disability and queerness in speculative fiction and art. Welcome, Kayla.
Thank you, Rodrigo. So here's my illness and disability story. I never had the best health growing up. I had several bouts of pneumonia as a kid and teenager, but I always recovered well. I wanted to go into the publishing industry and be a writer, and got a bachelor's in English with a minor in art. Then, 6 months after I graduated in 2007, I was visiting my parents for Thanksgiving and came down with strep, hepatitis A, and mono all at the same time. I was sick for about 1.5 years, and this time never quite recovered fully, although I was eventually able to move back out of my parents' house and start working full-time in 2009. Over the next 3 years, my health started going downhill again until I was barely able to leave the couch. That's when I started seeing a specialist and tested positive for Lyme. Despite this, I'd never noticed a tick bite, and I never had the bullseye rash, which I learned later is much rarer than people think. In certain regions, only about 40% of Lyme patients get the rash. At this point, I described my state as constantly feeling like it's 2 a.m. the night after I've run a marathon and gotten hit by a bus. Chronic joint pain, always feeling some level of exhaustion. And for me, the absolute worst is the cognitive and memory impairment from brain fog. I'm on SSDI, which is what's usually meant when people talk about being on disability. And most of my energy is spent just physically caring for myself. As for the intersection of my disabilities and queerness, the biggest thing I would like for doctors and care providers to take away is the importance of making sure your practice is proactively welcoming to all kinds of queer patients. As a queer person, you're always weighing the possible costs of being out to your doctor or anyone else, since it can involve losing your access to medical care, or worse, if you're out to the wrong person. As an agender person, I have to decide which is worse, taking it on the chin and being misgendered for a half hour, or possibly facing exclusion or violence. And I use a violent metaphor intentionally. Misgendering hurts, and sometimes it's enough to avoid seeking care entirely if the risk is too much. As an autistic person, I want to stress the importance of clear and exact communication. I went through about 6 months of increasingly complicated cardiac testing because I was having chest pain and shortness of breath. And every single time I saw a provider for a test, whether it was my doctor for an EKG or a cardiologist who hooked me up with a Holter monitor, they always asked me, "Are you under more stress than normal?" And the answer was always, "No, I am not under more stress than normal." It took another year for me to figure out that, yes, I had severe anxiety, because no one ever asked me what normal is. These issues of communication can result in people falling through the cracks. As for how state government agencies can help, I now want to touch on Social Security disability insurance. Although Social Security is administered at the federal level, the initial stages of the application process are processed at the state level. In Mass, this is done by the Disability Determination Services, part of the Mass Rehabilitation Commission. Nearly all of these applications are denied, despite applicants qualifying for the program and receiving approval at the federal level of the application, in part because those state level administrators are working with too narrow a definition of disability. Invisible illnesses are often excluded. It took nearly 2 years for my application to be approved, and I had to seek the help of a legal advocate. I'd like to ask the partnership and the Office of Health Equity to push for more comprehensive training in chronic illnesses for the DDS to help eligible applicants access disability insurance more easily. This is especially true now that we're probably going to have a large push of people suffering from long COVID and people from more marginalized backgrounds who might not have some of the resources that I did and the knowledge to be able to seek and retain that necessary legal advocate.
1 minute warning, Kayla. Sorry to interrupt you.
Really, all I want to say here is too many people are falling through the cracks as it is. And I want to see more of us getting getting the resources that we need.
Claudia Maria Carrera, MA, pronouns she, her, is a disabled Latinx academic, activist, and artist holding degrees from Princeton University and NYU. She advocates nationally with ME Action or hashtag ME Action for health justice for people with ME/CFS. Welcome, Claudia.
Thank you very much. I have severe ME/CFS, formerly known as chronic fatigue syndrome, which is a disabling neuroimmune disease. It's triggered by an infection in about 80% of cases and is now being diagnosed in countless COVID long haulers. ME/CFS affects millions of people in the US, yet it's been ignored and stigmatized by the medical and research establishment for decades, in part because it occurs most frequently in women. As someone with severe ME, I feel exhausted all the time and spend about 90% of each day in bed. Without taking anti-inflammatories, I also feel like I continually have the flu. I get chills and night sweats, I'm achy and moody, and just feel sick all the time. The part of my nervous system that controls automatic bodily functions isn't working well, which means I can't stand up for more than about 30 seconds at a time because my blood pools in the bottom half of my body instead of being circulated. It also means I can't tolerate temperature extremes. I have GI issues and my sleep is a mess. I cycle between all-night insomnia and excessive sleeping, which makes it impossible to keep a schedule. But my most limiting symptom and the core of ME/CFS is post-exertional malaise, or PEM. This means I have a certain very low energy threshold, and if I exert myself beyond it, I completely crash afterwards with all my symptoms flaring up. This happens not just with physical activity, but cognitive activity too. So because I'm participating in this event, I'm going to crash later and will feel pretty miserable for the next few days. As a result, I can't do almost anything in a day beyond eating and going to the bathroom without making myself worse. Yet in the moment, I appear healthy because I can do a lot of things, which makes it hard for others, including doctors, to understand how incapacitated we really are. As for my illness story, I'm actually in the minority of people with ME/CFS who didn't have a clear initial trigger. I've struggled with certain symptoms since childhood that gradually became more disabling, but I wasn't diagnosed until 2017 when I suddenly got a lot worse and developed the full slate of ME/CFS symptoms. At the time, I was doing a PhD at NYU and had been pouring every ounce of my limited energy into a dissertation project I was really passionate about. It broke my heart to have to leave the program and my whole life in New York behind in order to move in with my parents here in Massachusetts in my 30s so they could take care of me. Since then, I've watched my friends and siblings start families, reach career milestones, and travel the world while I've mostly been confined to a single room. Even without a clear trigger, it's possible infection played a role in my illness. As we now know from COVID long haulers, you can develop long-term symptoms from an asymptomatic infection you might never know you had. But there are also non-infectious routes to ME/CFS, or there can be a combination of different kinds of triggers in a multiple hits route to the disease. Recently, some people with ME/CFS have been finding out they have a structural anatomic problem physically impinging on their brainstem or spinal cord that may be contributing to their illness. I myself was diagnosed with a congenital spinal cord condition this year and just had surgery to correct it over the summer. It's still early and I've had to deal with some complications, but I'm happy to report that I've had positive signs of improvement in some of my symptoms. As a Latinx person born in the US to Peruvian immigrants, I want to highlight some of the barriers to ME/CFS diagnosis and treatment facing the community. Research suggests people of color may have a higher incidence of ME/CFS, likely because the documented health impacts of structural racism increase susceptibility to chronic disease. Latinx people are also overrepresented in the population of essential workers, and many work in crowded environments such as restaurant kitchens or meatpacking plants. Those who are undocumented face a particularly high risk of dangerous or unsanitary working conditions that may lead to an injury or infection that could trigger ME/CFS. Yet there's little awareness of ME/CFS in the community, and there have been no government outreach efforts to educate Latinx people and their healthcare providers. The vast majority of the information available online is in English, and finding it requires computer and internet access as well as research skills. To actually obtain a diagnosis or treatment, you need to skillfully and confidently navigate the American medical establishment, disregarding clinicians who dismiss your symptoms and seeking out the few who are able and willing to help. Yet access even just to basic healthcare is a challenge in the Latinx community, especially for undocumented people who often fear that going to a hospital or signing up for health insurance will expose their status to immigration officials. Language barriers, unfamiliarity with the US healthcare system, and racism in medical care further limit access to healthcare. Diagnosis and treatment also require financial resources. To confirm a diagnosis, you need to travel to see one of only about a dozen ME/CFS specialists in the US, most of whom don't accept insurance and charge hundreds, if not thousands of dollars. And the supplements and experimental treatments many of us rely on are rarely covered by insurance. Some Latinx people may also face more subtle challenges to accessing diagnosis and treatment. Personally, I grew up with an immigrant mentality that contributed to my reluctance to seek help during the decades I struggled with undiagnosed symptoms. I felt I just needed to work harder and push through to do what needed to be done, no matter how exhausted I was, and that it would be shameful, if not dangerous, to admit that I was barely keeping up. I felt like an outsider in many institutions who was not in a position to ask for assistance or accommodations, and I thought I could only rely on myself to find my way through however I could manage. So I'd like everyone to know it's not normal to feel this way, it's not your fault, and you do deserve help, which in the absence of institutional support, you can find in the generous and knowledgeable patient community. But there's a huge need for support from our state government here in Massachusetts. First, we just need more and better services for the disabled. While there seem to be full-fledged programs supporting seniors in every town across the state, I've been shocked that very few services are available to younger disabled people. For example, all the meal delivery programs servicing my area are exclusively for seniors or those with terminal illnesses, even though this would be hugely helpful for me. As for the services that do exist, many people with ME/CFS, myself included, are not receiving what they're entitled to on the federal, state, or local level because it requires huge amounts of cognitive energy to research what you're eligible for, go through long application processes, and appeal denials based on poor understanding of our condition. This cognitive burden is a huge accessibility barrier, but the services that help people access benefits only point you to resources. We need someone to actually make the calls on our behalf, fill out the paperwork for us, and follow up when there's a hitch. We also need the state to help us preserve telehealth access to healthcare providers, which has been hugely helpful.
Claudia, just wanted to give you that 1 minute warning.
Got it, thanks. And telehealth access has been hugely helpful to people with ME/CFS and other disabilities, but health insurance companies have already started to reduce or cancel coverage for virtual visits. As for the Department of Public Health, we need tracking for starters. We currently have no idea how many people in the state are suffering from ME/CFS or post-infectious conditions, and that means no attention or funding goes to them. We also urgently need to educate the public as well as healthcare providers. There's still little awareness that COVID can lead to long-term disability, and almost none that other infections like mono and the flu can as well. Publicizing this could help with the uptake of preventive measures, including vaccination. People also need to know how to spot the signs of these conditions and where to find more information. And healthcare providers need to be taught to recognize and diagnose these conditions, and especially how to treat them. Most are currently uninformed or misinformed and either misdiagnose patients or prescribe treatments such as graded exercise therapy that have proven to be harmful for people with ME/CFS. We need the state to make sure we're helped and not harmed by our doctors. Thank you.
Cynthia Adinig, pronouns she, her. Cynthia is a mother and graphic designer whose long COVID symptoms sent her to the ER over 20 times. With the Long COVID Alliance, Cynthia has been featured in the media, discussing the bias that she faced as a Black woman seeking life-saving care. Welcome, Cynthia.
I'm really blown away by the stories of everyone here before me, and I am going to give you my illness and disability story. Before I got sick, I was living my best life, multitasking supermom, a business owner. I ran 2 businesses, volunteered at my church, several nonprofits, all while homeschooling my young child. But then mid-March happened. My family and I got a very mild illness, runny noses, a light sore throat, mild fatigue, low-grade fevers, no cough, no shortness of breath, which meant we were denied access to a COVID test. Then in May, my life was forever changed. I had my first incident that sent me to the emergency room, and little did I know it would be the first of over 30 trips to the ER from long COVID. That night, I went to eat a piece of shrimp, my all-time favorite food, for those that know me, and I felt strange. My jaw felt tight. I couldn't swallow. My heart was racing. I felt dizzy. I didn't know if I was having an allergic reaction or a heart attack. At the ER, the test showed nothing alarming. The nurse told me it was an allergy or anxiety, but I knew something was terribly wrong. Plus, a few weeks later, it happened again. After eating a piece of fruit, my heart raced over 160. It was the scariest moment of my life when I had my first bout of temporary paralysis of my mouth, my arms, and my legs. I remember sobbing as my limp legs had to be dragged out of the car into the ER. Yet every single time I went to the ER, the hospital staff said nothing was wrong. So over the next 4 months, I became more and more hyperreactive to everyday foods and chemicals, including everyday cleaning products. I lost 50 pounds in 4 months and became a wheelchair user. Now, a year later, I continue to struggle with unprovoked bouts of exhaustion. When I get tremors from a flare, I'm back in the wheelchair. I'm still having trouble with mobility and fatigue and general physical exertion. I have regular bouts of brain fog, and I'm currently seeing a memory specialist to help with that. Concentration for me right now is so hard. It's impossible for me to complete simple tasks. The next question you gave us was, what else do I want to share about my illness and disability, speaking as a person of color and as a woman? And well, as a woman of color, I have an added set of challenges that when it comes to gaslighting and dismissal concerning care I receive in almost all medical settings, I find that I'm treated like a hysterical bother or as a violent threat, either based on my gender or my skin color. And last year, when I needed life-saving medical intervention, those biases caused a threat to my life. Here's one example. September 2020, I went to the emergency room because my oxygen was dropping to dangerously low levels. The nurse screamed at me to leave immediately. She refused to run tests. She threatened me with arrest and had hospital security push me out of the room in my wheelchair in the span of 5 minutes. Thankfully, I had the presence of mind to film this incident live, and later the Washington Post ran the video when they profiled my long COVID struggle. I later discovered that that very same hospital had drug tested me 3 times without my knowledge for illicit drugs. Even though I would test negative for illicit drugs each time, and I've never asked for pain medication, I was still treated like a dangerous drug-seeking criminal based on my race. I soon discovered other Black long haulers were also tested for illicit drugs without their knowledge while receiving care in the emergency room. Professors, firefighters, teachers. It didn't matter the profession, geographic location, or income. The same racially biased behavior and dangerous level of neglectful care occurred time and time again. As a society, I find that we continue to minimize the loss of life that occurs from a racial and gender bias, but it needs to be taken way more seriously. Though I'm able to tell my story, there are others who lost their life unnecessarily. That is something we all need to remember. And there continues to be this issue, even present day, with long COVID care in minority communities. Now, the last question you asked was what are ways that our state government, including Massachusetts Department of Public Health, can help someone like me?
1 minute, Cynthia.
Okay, perfect. So state government needs to do a better job at setting aside and expediting financial assistance for long haulers and other post-infectious chronic illnesses. Many long haulers are being evicted and becoming homeless due to disability and being unable to work, earn an income, and thus pay rent. Furthermore, the process of applying for Social Security disability is cumbersome for those of us with cognitive impairments, and the approval process can take years. So how can anyone avoid eviction when financial assistance lags behind our need? I know 2 people with long COVID who are about to be evicted, another 2 that became homeless. Recently, one long hauler who became homeless died hours before his disability application was approved. Speaking about Social Security disability, since we are immune compromised and vulnerable to reinfection, we need Social Security evaluators to mask up. I have a friend who is also a Black woman who requested her evaluator to wear a mask. He became hostile and irate and refused to continue the evaluation. And yes, he was white. There are many chronic illnesses that overlap in terms of symptoms, disability, and a need for government assistance. Lyme disease, ME/CFS, and those with other post-infectious chronic illnesses have the same issues as long COVID. State government needs to do a better job at educating doctors and specialists on how to treat us and those illnesses. And thanks for having me.
Now I will introduce our next speaker. Alfred DeMaria, Jr., MD, pronouns he, him, is a medical and laboratory consultant at the Massachusetts Department of Public Health, where he previously served as medical director of the Bureau of Infectious Disease and Laboratory Sciences, and for many years as the Massachusetts State Epidemiologist. Dr. DeMaria, a fellow of the Infectious Diseases Society of America and president of the Massachusetts Infectious Diseases Society, serves on multiple committees of the Massachusetts Medical Society. Welcome, Dr. DeMaria.
Thank you, Rodrigo, and thanks to my co-panelists for presenting their experience, not only with their illness, but with how their illness and they personally have been treated, because I think it's given us a lot to think about. And what I'd like to do is sort of share some of my thoughts about post-infectious syndromes. And this comes from years of being interested in ME/CFS and other similar syndromes. And when I first started hearing about long COVID, the things that were described, like postural hypotension, brain fog, etc., reminded me immediately of ME/CFS. And to this day, I'm still seeing that connection not being made. And I think part of this problem is that many of my colleagues see these as psychosomatic illnesses. And maybe we could have the slides up. I don't really need the slides, but it might help to for people to follow along. So many of my colleagues think of these as psychosomatic, and clearly what we're talking about here are organic illnesses, well established, ME/CFS, now long COVID, chronic Lyme disease, post-Lyme disease syndromes are clearly organic. And I think one of the difficulties we all have is that many people still don't recognize this, and this contributes to the way people are treated. And many infections can precipitate a similar syndrome. And there have been outbreaks in the past, outbreaks of ME/CFS in various localities. Even in the end of the 19th century, there was a pandemic that has been thought to been due to influenza, but we're actually now, many people think we're another coronavirus emerging, where many people had very similar syndromes to long COVID after that outbreak. So these are associated outbreaks, and as already pointed out, can be associated even with minor illnesses, maybe not noticed, or even illnesses or infections without illness associated with asymptomatic infections. So, and when I talk about a syndrome, I know no two people experience the same illness in the same way. So there are symptoms associated with post-infectious syndrome, like fatigue, like pain, like post-exertional malaise, like postural hypertension, which could be represented in an increased heart rate. It's not always that people pass out when they stand up, but they may just have a persistent high heart rate to try to compensate for that postural hypotension. Brain fog, pins and needles. So there's a lot of these, and people experience them differently, and they may have other issues, other problems associated with their symptoms or associated with the original illness that led to their symptoms. The next slide, please. So I'm talking from hypotheses because we don't have all the answers, but I can tell you, as someone who, and I think this is unusual, I go to conferences and listen to research presentations on ME/CFS, and I also go to conferences and listen to research on the chronic consequences of Lyme disease. And I hear similar presentations of explanations for these, potential explanations that involve dysregulation of signaling pathways. So when we get an illness, when we get an infection, it triggers a certain response. And that response during the actual acute infection can be beneficial, presumably is beneficial because that's why it's happening. But if that's not turned off, if those genes are not, the expression of those genes are not turned off, then you have these continuing, and these signaling pathways can cause symptoms, and they can cause symptoms very similar to what we've been discussing. And then no illness is just itself. It's occurring in an environment, it's occurring in a particular individual. So we all have genetic predispositions, and maybe a genetic predisposition is contributing to these syndromes. And we live in an environment that's full of stimuli and potential effects on environmental effects on illness. So people say, well, these people have this and these people have that, and they have different symptoms. I think we have to sort of look at this as an expression of different syndromes in different people under different circumstances. And also precipitating illnesses can have chronic effects that have nothing to do with the post-infectious syndrome. So in other words, let's say you have long COVID, but you also had lung damage during your acute COVID-19 illness. That lung damage can lead to symptoms that are superimposed on the post-infectious syndrome. And another example of this would be Lyme disease, because you can have direct joint destruction, direct joint damage due to Lyme disease superimposed on a post-infectious syndrome of fatigue and muscle pain and postural hypotension, et cetera, things we've already discussed. So I think we have to sort of understand that there's this overlap of the effects of this acute illness. Now, even there's something called post-ICU syndrome, which can lead to prolonged, persistent symptomatology after being in ICU, being on a ventilator, and that could be superimposed on this syndrome. So I think we have to sort of understand this in its full context. Next slide. As the previous speakers have so eloquently discussed, people are not treated well. And that there's a number of reasons for this. And now we're hearing that people with long COVID are hearing similar things that people with ME/CFS, post-Lyme, post other infectious syndromes have heard in the past, that we don't really understand it, therefore we can't do anything for you. There's no pill for it, we can't do anything for you. And, pull yourself together, get a grip, you're not pushing yourself. So, and this is a fundamental misunderstanding of what's going on with individuals, and is unacceptable. Now, it may not meet the formal definition of patient abandonment. I'm not even sure what that is, but to me, if you tell somebody there's nothing you can do for them, you're not doing your job, because the job isn't just prescribing the appropriate pill for the problem. The job is dealing with the issues that the patient is presenting. And I've thought about this a lot over the years. And, I think the medical community, the public health community has to come together and send a strong message about what these syndromes are, what kinds of things people are going through, and try to address some of these underlying things. We're dealing with a lot of underlying things in our society that make it difficult for people, and this is another one. And I think by people telling their stories, by people understanding context, by people sort of understanding why people react in certain ways to certain things, is very important for us going forward, because it's the perception, it's the perception of the person looking at the person with the disability. And we already sort of saw examples at the perception that, you're just coming, you're just seeking care, go away, take care of yourself. Or
1 minute, Dr. DeMaria. Just wanted to give you that 1 minute warning.
Yep, thank you. Or the perception that, oh, you look fine, come on, pull yourself together. You're not as sick as you think you are. Because one of the things I've learned in my career is you can't know the pain somebody's experiencing. You can't know the symptoms somebody's experiencing. You can only listen and use judgment and do whatever seems to be the best for that patient. So let me stop there, because I want to hear the Q&A and I want to hear more from our other panelists.
Thank you so much, Dr. DeMaria. Okay, we will now open our panel for a 20-minute question and answer session. We will have two people fielding your questions, Nasra Nicola and Anna Philaxis of the Health and Disability Partnership. Welcome, Nasra and Anna.
Hello. So this is Nasra Nicola from MassDPH and the Health and Disability Partnership. And the first question goes out to all of our panelists. I hope someone can touch on post-viral POTS, postural orthostatic tachycardia syndrome, especially given the surging number of patients due to COVID infections producing a post-viral POTS diagnosis. And I know Cynthia or Claudia, you had something to say about that, and I suspect others might as well.
Sure. So POTS is very common, as you've heard after from our different presentations, and it's something I actually think I experienced for a long part of my life, and it just feels like initially, before I was measuring my heart rate and everything, it just felt like I couldn't tolerate standing up. I would get these moments like outside or, at college where I just wanted to be horizontal, and I'd even like lie down on the grass for a while. And some people actually will faint and pass out because their hypotension drops too quickly. And other people will get, dangerously racing heart rate, as Cynthia described. And so we're lucky that here in Massachusetts, we do have some cardiologists who are POTS specialists. And there's also some neurologists who work with dysautonomia. Dysautonomia is what I described as the failure of your body's system to regulate and control the automatic functions like circulation to be able to make sure that you can tolerate standing up without passing out. And there can be some treatments for it, which can include loading up on salt and electrolyte drinks, taking some medications, there's a few different ones, and using compression tights or abdominal binders. So those are a few strategies. I hope that answered what the person was wondering.
I do think it's worth mentioning, reading out the statistics that the question asker gave us, which is that there were roughly 70,000 POTS patients in Massachusetts prior to the pandemic. There are estimated to be 201,624 people in Massachusetts dealing with long COVID, according to AAP-MNR, with roughly half dealing with autonomic dysfunction, potentially including POTS. So it's easy to see why this is a very important consideration.
Yeah. Next question. So this was marked as a question for Rodrigo, but I think several of us, again, might have answers. I'm wondering why it's so hard for illnesses such as ME/CFS to be tracked by public health departments. We truly need the barriers removed. And yeah, if Rodrigo, if you want me to talk about disability data collection, I am more than happy to do so.
Sure, go ahead. And I think also Dr. DeMaria, as a medical doctor and an epidemiologist,
epi.
Yeah, might be able to shine some light on that.
Dr. DeMaria, I will let you go first.
I just say, traditionally we've focused on infectious diseases in terms of surveillance. And I think we've come a long way with non-infectious disease surveillance in many realms. And a lot of it has to do with the visibility of the illness. Illnesses that are visible and that sort of attract the attention of the public and the policymakers tend to be the ones that get surveillance done for. And, I think that fits in with the title of this program, is that invisible diseases that don't get that kind of public attention commitment don't tend to get tracked. Now, there are technical issues in terms of how do you track an illness. Most of the infectious disease most of the infections we track now, we track those through laboratory results. And the idea that clinicians are reporting infections really is not the story. It's mechanized, it's automated. So that it's very difficult to do surveillance for diseases you can't sort of capture that way. And that's another problem with invisible disabilities, invisible illnesses.
A audience member wanted to ask Kayla if they would be comfortable speaking more about how the Massachusetts definition of, I assume CFS, interferes with qualifying for SSDI.
With the caveat that I'm not a disability lawyer. I'm not a lawyer of any type, so I can't get into real nuts and bolts. When you apply for disability, your application goes through 3 stages, and you can be approved or denied at each stage. The first stage is a very long written questionnaire along with reports that you send in from your doctors, describing what your diagnoses are, what your symptoms are, the effects it has on your life. And that is sent to the Massachusetts Rehabilitation Commission and the Disability Determination Services, and they will say approved or denied. And if you get denied, you then apply again, and again, it's another set of questionnaires and doctor's reports, and then in-person evaluations, again done at state level by Disability Determination Services. And it's with chronic illnesses like post-viral syndromes and newer or just lesser known diagnoses and disabilities, you're much more likely to get denied at either or both of these stages if the people responsible for looking over your application, don't know what, post-Lyme syndrome or ME/CFS are, and don't know what they do to you and how they affect your life. Usually you will have to go to the 3rd stage of being, physically interviewed by a federal judge who works in the Social Security Administration Determination Services before your application gets approved and you start getting disability insurance payments, which are can be life and death for a lot of people. And this is why it's really important. And, I wanted to stress getting the Massachusetts state employees working for the disability determination services to be more familiar with these syndromes and illnesses to make this process just more manageable for more people to get the assistance and help they need.
Thank you so much, Kayla. So a question for Dr. DeMaria. All the speakers, including you, indicated something to the effect of the state needs to do more to ensure that doctors know how to help and not harm us. As a career government health professional, bless you, what can you suggest that we as advocates should be doing to help the state fulfill this mission?
I think that visibility is very important. You can't expect, there are a huge number of inputs coming into the state agencies. And you have to sort of find a way to bring your issue to the forefront and get the political support. I think it would be very helpful if there was a consensus definition of these post-infectious syndromes. Right now, the problem is, as I said, no two people experience the same illness in the same way. So, I think you can't include everything. You have to come up with some core that is understandable to people, core set of symptoms, and understand that people can have other symptoms and they may or may not be part of the same syndrome, but sort of come up with a definition of what we're talking about here. Because, there was something in the Q&A that said, someone was told that they can't have ME/CFS because they just had COVID. It must be COVID. Well, they could be the same syndrome. And until and unless we look at this in that sort of holistic way, everybody's going to be going after individual illnesses and not at the core of what's going on in people's lives. So I think there's some work to be done in terms of better defining the illness, and there's some work to be done in terms of coming up with one specific, relatively narrow definition and ask for the government agencies.
If I can just poke my head in again, as a state government worker who came to state government from the advocacy sphere, one thing that would be incredibly helpful to me in my job is I can't make policy most of the time. My job is to implement policy. And as a state employee, I'm also not allowed to advocate for policy changes. No matter what I personally believe, I implement the policy as written, which means that if you have advocacy to do, really knowing who to bring that advocacy to and taking it to people who have control over policy would be tremendously useful. Not just in terms of saving your time and not talking to the wrong person, but also in terms of doing the advocacy that I have sacrificed my ability to do in order to do the rest of my job. And I think a lot of state workers, you'll never know our true opinions about a lot of things. And so if there is advocacy to be done, data about disabilities and about health conditions and public health surveillance are a matter of public record. You are absolutely free and encouraged to request data from us, and if we have it, we have to give it to you. And then I think what we need is a well-crafted message taken to people with the power to change policy. And Cynthia, you said you had something to add as well.
Yes. So before I got sick, I was very into policy and legislation. So one of the things I knew to go straight to my local delegate who is in the hospital areas where I was being mistreated in the hospitals, explain to them what was happening, explain to them the loopholes that was allowing this behavior to happen. I eventually was able to talk to our state representative, tell them my story, and through that, I was able to get policy change introduced as legislation for when it comes to bias and teaching doctors and providers about not just bias, but about chronic illnesses. And so it can be done. You just definitely figure out who is going to be the one that can help you, and go there. It doesn't matter how much you complain about it, like online, or if you're not in front of the right spaces, you're not going to get that change. And you definitely want to use, especially for those that are chronically ill, all your energy is so precious. So you don't want to waste your time and energy talking to the wrong person. So that would be my advice for someone that wants actionable change on the federal and state level when it comes to chronic illnesses.
We were asked if any of the panelists could speak to the issue of workplace accommodations, either accommodations that they personally have sought and found useful in the workplace to help them with working with their disability, or issues they face trying to get those accommodations. I can certainly say, just speaking as an advocate, that I have been approached many times by people who have sought to get workplace accommodations and have genuinely struggled to find workplaces that were willing to work with them or listen to them to reduce time or give them time off or things such as that. It's definitely a serious problem.
And I mean, a lot of that is why there are so few people with disabilities in the workforce.
I can add that some of the things that you can try to request are like working from home. Now, thanks to the pandemic, much more common, is hugely helpful, especially if it means you can lie down while doing your work for those of us with POTS. Again, going part-time if you're able to is a huge help. Having flexibility is huge too, if you can choose when to do your work instead of having to be on a schedule, because you can't predict when your symptoms are going to flare up. So it's hard to find workplaces that are willing to provide these things, but those are some things to think about asking for.
And as someone who is in the workplace but often doesn't know what I need, I just want to plug the website askjan.org, askjan.org. They have a searchable database of different types of accommodations that people have found useful for different symptoms or conditions, and that can give you a place to start in terms of thinking about what you can ask for. And then once you do, typically you would go to HR or the ADA coordinator in your workplace. They'll tell you what documentation they need, and you can go from there. And askjan.org is a federal government resource in the US, but also anyone can access it as long as they have internet access.
I want to thank all of our panelists and speakers, and Nasra and Anna for helping to facilitate the Q&A. Thank you so much for your personal stories, your insight, and your research. Can we show our gratitude maybe with some applause and thank you so much, or in the chat if you folks have already been putting some of their comments there. Now, next, we're going to provide contact information for the organizations that hosted this event, as well as a list of resources for the chronic illnesses that we discussed today. We will read these aloud for accessibility, and that means it'll take a little time. And if you are interested in learning more about the Health and Disability Partnership, please stick around after we go through the resources, because we'll be talking about how to contact and even how to join the partnership. And I know that questions did come up about that as well. So, well, the contact information for the Health and Disability Partnership and for Mass ME/CFS are on the screen. I'm going to read it. To contact the partnership, you can email Nasra Nicola or Kimberly Warset. Nasra's email is nassira.d.nicola@mass.gov. That's nasra.d.nicola@mass.gov. Kimberly's email is warSett@mass.gov. So note that Kimberly ends with EY, and that's kimberly.warset.mass.gov. Actually, at mass.gov, I'm sorry. You can also contact the Massachusetts ME/CFS and FM Association. To contact Mass ME/CFS, please email contact@massmecfs.org. That's contact@massmecfs.org. Now, we have prepared a list of resources to help you learn more about the disabilities discussed here today. We will enter them in the chat and we will read them out loud. And they're also on the screen. This will only take a few seconds. The announcements from the partnership will actually follow the resources. So, Eric, if you wouldn't mind entering the URLs as I read them out loud, that would be great. Starting with resources for Lyme disease. There's the International Lyme and Associated Diseases Society, or ILADS. It's ILADS. There's LymeDisease.org. There's Global Lyme Alliance, and there's Lyme Disease Association. For ME/CFS, there is Massachusetts ME/CFS and FM Association, or Mass ME/CFS. There's ME Action, or hashtag ME Action. There's American Myalgic Encephalomyelitis and Chronic Fatigue Syndrome Society, or AMMES, spelled AMMES. There's Solve ME, and their website is solvecfs.org. So that's SOLVECFS.org. And finally, for long COVID, there is Long COVID Alliance, and there's Body Politic. Their website is wearebodypolitic.org. That's We Are Body, POLITIC.org. Look for the section labeled Resources. And then there's Patient-Led Research Collaborative for Long COVID. Their website is patientresearchcovid19.com. That's patientresearchcovid19.com. Look for the section labeled Publications. We sincerely hope these resources are helpful to all of you. Now, this concludes our program. I'm going to hand it over to Anna, the representative from the Health and Disability Partnership, for their announcements. Thank you so much.
Thank you, Rodrigo. And thank you to everyone for attending and to all of the panelists for their fantastic contributions. This has just been a wonderful panel. Our back matter begins with member announcements. I believe Nasra is checking to see if, okay, we do not have member announcements this time. So I'd like to remind all of you that the Health and Disability Partnership is an organization that is focused on us disabled people. And we are always looking to get more disabled voices involved in our process. I'd like to really encourage you to follow up on the links posted and the information that was included. Nasra does have one announcement. Nasra?
So the Health and Disability Program at Mass DPH, as well as many other DPH programs, are starting new grant cycles, and many of us are looking for staff. So if you are in the state of Massachusetts and are interested in working in the public health field, I strongly encourage you to go to masscareers.org or .gov? I should have checked. Go to the Mass Careers website, which you can Google, as I have failed to, and check out the jobs that are being posted pretty much on a weekly basis at this point. Degree and experience requirements vary depending on the type of job, but job requirements and salary ranges are listed explicitly for every position. So yeah, I look forward to possibly even working with some of y'all in the near future.
Just a few last things to say. Our next meeting will be December 2021, and the 2021 Partnership Survey results will be coming soon. So I'll just thank you again for attending, and thank you to our panelists.